виспер нам еще один. Если что, делаем тогда модификацию. Может, сейчас перевести его в этот виспер. Не надо перепроводить. Ну, можно так попробовать. Попробуй давай.
Hello, good afternoon.
Hello, everybody.
We can see you. You are live.
Yeah. Welcome to Moscow. Welcome to Government Treatment and Rehabilitation Center. So my name is Sergey Volkov. I am a main operator today. So and my assistant Sergey Mytsyk, and our team nurse Inna, and anesthesiology team Dr. Vladimir Chepilin, and nurse Vera. So, and also I would like to introduce our case. So, Alexander, could you show the slide, please?
Yes, sure. Good afternoon, dear colleagues. I will briefly present the clinical case. Our patient is 66-year-old woman with a clinical picture of angina pectoris, class 3, according to the Canadian classification. She was diagnosed with multivessel coronary artery disease, and the first step of her treatment was stenting of right coronary artery 1 month ago. Next, I will show you the results of coronary angiography and the stenting. There are no prior history of myocardial infarction before. Among the risk factors are arterial hypertension and dyslipidemia. This is the initial angiography. You can see that the severe stenosis in the middle of LAD. It's a bifurcational stenosis, Medina 111. And TIMI 2. Let me show you the occlusion of obtus marginal. This is the initial angio of right coronary artery and the following stenting with drug-eluting stents. After 1 month, after the stenting of right coronary artery, the stress test, the stress echocardiography was performed, where signs of deterioration of local contractility were detected along the front and lateral wall of the left ventricle. This is the result of scoring. Euroscore 2 1.10, syntax score 22, syntax score 2 for PCI was 34.4, for KGB 20.2. This is the final result of scoring of syntax score. You can see the syntax score 2 recommendation was KBG, and despite the fact that according to the results of the assessment of the KBG is preferable, the patient refused open surgical treatment initially, and now she's in our operation room, and I pass the word to them. Thank you.
Okay, thank you, Sergey. Before starting discussing the strategy, I want to introduce the panel. We have Dr. Mazzarotto, Dr. Butzner, Dr. Stanna, Dr. Tumschitz, and Dr. Ferro. And now we leave you discuss the case and the strategy and what you have done so far. Thank you.
So yeah, now first of all, we decide to start today with circumflex artery and marginal branch. You show the initial angio. So it's also left descending artery. So we pass whisper wire through the lesion, a little bit resistant. So, but after we did predilatation, balloon 2.0. After that, we check our artery by OCT. Could you show OCT, please? So now you can see some dissection in the distal part of lesion. So, and the diameter of artery in the distal part 2.48, and the it's a proximal part, and the distal part it's 1.64. So we decide to put everolimus luting stent synergy 2.5 and the length of 28, and you can see the final result. So after stent implanting, we decide to proximal optimization in the proximal part of circumflex artery. It's a non-compliant balloon 2.75. So it's a final result, and after that we check again by OCT. Could you see OCT imaging?
Yes.
Yeah, look, it's a well opposition of stent, and distal part, and the medium part, and the proximal part. Yeah, it's a good result. And after that, we decide to treat LAD. So we put the first wire in the distal part of left descending artery, and after treatment to put the second wire to side branch, it was very difficult because the angle it's not good for easy pass, you know. So, and now we decide to modify lesion by balloon angioplasty. So, come on. So we put the balloon 2.0. Could you check the test, please? Okay, раздавай. Давай на съемочке. A little bit better right now, and after predilatation I would try again to go by second wire in the side branch.
Is that a 7 French guiding?
No, it's a 6 French guiding. Because we are working through radial approach today.
So meantime, I will ask to the panel which would be the best, your first strategy for this bifurcation, single stent or two stent?
Yeah, we're thinking about our strategy, and we have 2 plans or maybe 3 plans. First of all, we maybe try to use, if we talk about double stent technique, maybe we try to use Collot technique, or maybe we try to use mini crush or decay crush. But as you know, if we try to decay crush, it's more easy to do it through 7th range, of course.
Which wire are you using to wire the diagonal?
First wire is Xeon blue, and the second one, when I try to put it inside branch, it's Whisper. Покажи. Еще.
There is diffuse plaque on the LAD. This diffuse disease. This may be the challenge to wire the diagonal branch. In these cases, sometimes a dual lumen microcatheter can be helpful.
Сделайте чуть погромче колонку, потому что мне не слышно.
With the 6th branch, in terms of trapping afterwards, you have to use a small caliber dual lumen like an answer for X or Sasuke. But that could be an option.
Yeah, maybe.
Tapping technology. And also the recross that Roberto has used, and which is also compatible for 6th branch guide catheter for tapping.
Давайте. Виспер еще один откройте. Виспер.
Вот он что-то проскочил у меня.
Сейчас зайду.
Покажи еще пробу. Нет, не там.
And I think that the angle of the diagonal is the origin is 90 degrees. There's no disease, actually, probably no significant disease. And my strategy in this case would be to go for a provisional stenting. Of course, we need to
maybe it's a good.
And
maybe it's a good idea because we have some problem to put the wire on the side branch. Maybe try to provisional stenting, and after that to decide what we need to do with side branch. So, okay, I changed my plan.
There's a question from the audience, and the audience is asking why you choose to treat the left circ first and the LAD afterwards.
It doesn't matter. If you want, you should try to leave the stent artery, but we start a little bit early before live transmission, and we decide to treat, first of all, circumflex. Could you open the balloon 3.0?
Трешечку.
See some ST elevation in the lateral leads.
Yeah.
Is the diagonal still open, or?
A little bit of elevation, but the patient don't feel some angio symptoms. Yeah, now she is on fentanyl infusion.
So what would be a strategy? Now take a bigger balloon and try it again, or just stent the LAD and hope that the diagonal will be accessible. Both possibilities. In case of ischemia, eventually it would be a good idea to just stent the LAD.
Yes, one hypothesis is that the dissection created by the balloon could stop the flow in the diagonal, so maybe stenting could be an option.
Готов?
Давай
со съемкой, да.
So what size is this balloon?
Давай.
Это трешка.
Аккуратно, на номинале.
It was 3.0, yeah.
3.0.
Знаю.
Still not expanding.
You can see some little bit resistance in the middle part of balloon. Maybe we try one more time.
Non-compliant balloon?
Sorry?
Is it a non-compliant balloon that you use?
Compliance.
Yeah, it's no, it's compliance balloon. Давай.
I have a clear idea on the plaque distribution in the bifurcation. You said that it's
Новый виспер.
a Medina 111, correct? So is it the side branch disease or not?
Дай чуть пробую сейчас я. Так, готов.
I don't know if I can give you a suggestion. I think fixing LAD now
У
it
меня
seems to be
оба контраста
important.
закончились.
Could try to get diagonal, but you lose the flow to LAD also. Maybe if you fix LAD, you can work on diagonal more calmly and then find a way.
So now you can see the side branch, it's a little bit closed. So what do you think? What about this strategy? Try to put the second wire in the distal part of side branch, or treatment just provisional stenting, and after that decide what about side branch.
Was another suggestion from the audience, as we said before, that one option could be to use a dual lumen microcatheter to wire the diagonal branch. Because I think actually that the diagonal branch is a big branch. Now it is occluded. If you put a stent, it will maybe much more difficult to get inside if you have any flow. So I think that it's worth it to spend some time to trying to get to the diagonal branch if the flow on the LAD gets good.
I always agree because the HEG is better and patient has no symptoms, and you have time to work, spend more time in dual lumen and using a wire, Sion wire, Sion blue wire, and get the diagonal.
Может быть, еще понадобится сейчас нам корсар.
Wire are you
Модифицированный.
Ну, нет, корсар не модифицированный, такой обычный.
Seems a polymeric one, right?
Which one? In this case, a polymeric or a hydrophilic or what? At least at tip.
Yeah, the tip, hydrophobic tip,
Hydrophobic.
blue wire with the hydrophobic
Что лечение дать?
А это какое?
Второе.
Polymer-coated wire.
Дай третье, давай.
With steered or sloppy wire.
Also, Sion wire could be a good choice. It's really hydrophilic,
Покажи.
but spin coil without polymer.
Probably
It's
not.
safe.
I think at least I would try to go with a microcatheter down, even a single lumen or dual lumen microcatheter. Also a single lumen might do it. Bring it down over the LAD,
Еще.
then retract it and try to enter with it, eventually even with a
Sure.
feeder XR or something like that.
So probably we need some adjunctive devices beyond the guide wire. So microcatheter could be a dual lumen, a single lumen straight microcatheter, or also if it is available, a bended tip microcatheter that can be very useful in these cases.
Eventually it's plug shift intersection, and the risk is that we enlarge the
Okay.
sections now when we go to their diagonal. If it wouldn't work, I would even stent it to rearrange the anatomy.
And I would also try to change the view. Take off of this.
Yes, maybe a cranial view maybe help them, because it seems the guys were always stuck in a dissection plane before the ostium.
What wire are you using now for the diagonal?
Давай что, попробуем с корсаром, нет?
Да, он у нас есть модифицированный.
Давай.
Корсар откройте, который загнутый.
Не, ну он
Нет?
не загнутый, по-моему.
А ну-ка.
Прямо покажи. Еще. О, ну-ка дай. Это мы там, нет?
Да, похоже очень.
Давай на съемки.
Okay.
So we passed through the lesion and now we are in the distal part of side branch.
Открыто у меня воздух подсасывает постоянно.
So, давайте
Баллон.
мне два баллона, две двушки.
Не, оба ножи.
Второй эндофлятор откройте.
So now you are planning to dilate the diagonal branch, I imagine.
Yeah, I try to do some kissing dilatation. And first of all, it's just second branch, side branch. Держишь?
Да. Си.
Угу, держу. A little bit resistant. Ну, покажи, попробуй чуть-чуть.
Eventually, what was the
So,
confliction?
дайте баллон полторашку.
Нет, нужно просто открыть
There's
новый.
some defect.
Да, полторашку баллон.
Was that a new balloon or a balloon that you already used?
It's a already used balloon, but now we are trying to do new one.
А это какой? Двушка? Ну, двушку.
Новый?
Да.
Мгм.
Полторашку положи пока.
Now it's a 2.0 balloon. It's a new one. I fixed. Yeah, it's a new balloon, much better than the previous one. Давай, подключаемся.
ну.
Ну. Поехали. Давай. Давай на съемки. Покажи чуть-чуть, Сереж. Угу. Okay.
No.
So, what do you think?
It's reopened. Okay.
Now the flow on the diagonal branch is good. I think that now we have to decide if going for a single stent strategy or a double stent strategy. This is what we should decide right now.
But maybe there is a dissection in the mid-distal part of the diagonal, I don't know.
I'm not sure there was the balloon inside.
Yeah, a little bit dissection, but maybe, what about maybe intravascular visualization by OCT? because it's my opinion, it's the same size.
In this case, probably.
Yeah. Come on, OCT.
I think it would be helpful to have a second view on the bifurcation to see the true bifurcation angle, maybe LAO far cranial, and to then decide on a strategy.
Калибруемся.
In the diagonal seems to
Давай,
be longer
поехали.
than at least
Ну, я готов
section
калиброваться.
the system strategy would be the right one. And both these two vessels have a very nice lumen, a very nice diameter.
My strategy and my idea right now check by OCT side branch diameter because I think by angio it's the same size like left descending artery, and maybe we try to do exercise this situation to use some maybe culotte technique, for example.
Yeah.
So you use OCT only for sizing the side branch.
Гайд надо поставить будет.
Покажи чуть поровнее. Вот так вот. Готов?
Да.
Все, давай так. Ну, хорошо, можно поглубже еще. Вот так вот, давай, поехали. Я готов. Начали?
Я тоже.
Старт.
Когда часы пойдут, начну вводить.
So now we have OCT imaging inside branch and the proximal part of LED. I think the distal diameter will be approximately 1.7 or maybe 1.8. Покажи нам ту самую осетишную картинку просто.
Диаметр.
Дистальная часть сколько? 1,68? 1. So 1.85. It's a distal diameter. 2.2.
2,5. Меньше не надо ставить, чем по виду.
Окей. Два с половиной.
Okay, unfortunately, we are running out of time, so just tell us the strategy. I think you will go for a double stem technique. Are you going to do a decay crush?
Yes, maybe we decide about decay crush, or maybe culotte, as I said. So because for decay crush we need to optimal 7th range guiding catheter, you know.
All right. Yes, that's true. Okay, so Thank you very much for this live demonstration. Unfortunately, we have to close the live transmission, and hope to see you soon.
Yeah, thank you.
Bye-bye.
Bye.
Thank you.